Let me ask you something personal. Do you take a small pill every morning for your blood pressure? And in the last year or two, have you noticed that climbing a flight of stairs leaves you more winded than it used to? That your weight has slowly crept up even though your eating habits haven't really changed? That you feel this kind of tiredness that just sits on top of everything no matter how much sleep you get? If you said yes to any of that, I really want you to stay with me for the next 15 minutes, because what I'm about to share with you changed the conversations I have with my own patients. And it might just change the conversation at your next doctor's appointment, too. I'm Dr. Robert Harrison, and I want to start by being upfront about something before we dive in. This topic has real nuance to it. I'm not here to tell you that some class of medications is just bad and you should stop taking them. Medicine is never that simple, and I'd be doing you a disservice if I pretended it was. What I am here to tell you is that the research around one of the most commonly prescribed blood pressure medications for seniors has shifted pretty significantly over the last 20 years. And right now, millions of older adults are taking a medication that was prescribed years ago without anyone sitting down to ask whether it's still the best fit for them today. The medication I'm talking about is the beta blocker. You probably know it by its brand names Topol, Loesser, Tenorin, or the generic names Metoprolol, atenolol, Prescribing. These drugs have been prescribed for high blood pressure for over 5 decades. They're inexpensive, they're familiar, and for a long time, they were genuinely considered the go-to treatment for hypertension. Tens of millions of prescriptions are written for them every single year in the United States. And a huge number of those prescriptions belong to adults over 60 who've been taking them for years, sometimes without a single formal review of whether the current evidence still supports that decision. Before I go any further, I need to say something clearly, and I really need you to hear this. Do not stop taking your beta blocker on your own. Not today, not after this video, not before you've talked to your doctor. Stopping a beta blocker suddenly, without medical supervision, can cause a dangerous rebound effect where your heart rate and blood pressure spike fast. In some cases, that rebound can actually trigger a heart attack or a serious heart rhythm problem. Any change to your blood pressure medication has to be done gradually over weeks under your doctor's direct supervision. What I'm giving you today is information and the right questions to bring into a medical conversation. It is not permission to go open your medicine cabinet and make changes by yourself. This really does matter. So please take it seriously. Now, let me explain what a beta blocker actually does inside your body, because I think understanding this makes everything else make a lot more sense. Your heart has receptors on its surface. Think of them as tiny locks. Adrenaline is the key that fits those locks. When adrenaline connects to those receptors, your heart beats faster and with more force. Beta blockers work by sitting inside those locks, so the adrenaline simply can't get through. That slows your heart rate and reduces the force of each beat, which brings blood pressure down. And for certain conditions, that is exactly what you need. Someone recovering from a heart attack, someone managing heart failure, someone with dangerous heart rhythm problems. In those situations, beta blockers are genuinely important medications with solid evidence behind them. But the question I want to focus on today is much more specific than whether beta blockers ever work. They absolutely do in the right situation. The question is this: for a senior whose only medical issue is high blood pressure with no prior heart attack, no heart failure, no arrhythmia, what does the current evidence actually say about beta blockers compared to the alternatives we have today? And what has emerged from over 2 decades of major clinical research is something that every senior on a beta blocker deserves to know. The 2017 American College of Cardiology and American Heart Association guidelines do not list beta blockers as a recommended first-line treatment for uncomplicated hypertension. The 2024 European Society of Cardiology guidelines similarly don't include them in first-line FO therapy for most patients. The real turning point in this story came from a landmark trial called the ASCOT trial, the Anglo-Scandinavian Cardiac Outcomes trial published in The Lancet in 2005. And this was not a small study. It enrolled 19 through 257 patients with high blood pressure and followed them for 5.5 years. The trial was actually stopped early because the results were that clear and that significant. The group receiving a calcium channel blocker-based regimen had 23% fewer strokes, 11% lower all-cause mortality, 16% fewer total cardiovascular events, and 30% fewer new cases of diabetes compared to the group on the beta blocker atenolol. The trial was stopped because continuing to keep patients on the beta blocker arm when those numbers were that striking was considered ethically unjustifiable. Now I want to be precise here because the nuance genuinely matters. Ascot specifically compared atenolol against amlodipine, which is a calcium channel blocker. Atenolol is an older beta blocker, and there has been real scientific debate about whether all beta blockers carry the same profile as atenolol or whether newer agents like carvedilol and nebivolol behave differently. Some evidence does suggest they do. The European Society of Hypertension in their 2023 update actually retained beta blockers as an optional first-line therapy, noting that their overall benefit data is substantial. The scientific conversation is still evolving, but here is what is not debated. Beta blocker-based treatment in the Ascot trial was associated with twice the rate of fatigue, significantly more bradycardia, more dizziness, and more shortness of breath compared to the calcium channel blocker arm. Those are quality-of-life consequences that land heavily on a senior body. Now let me talk about the metabolic issue because this is the part of the story that I think is most underappreciated in conversations between doctors and their senior patients. Beta blockers increase insulin resistance. They raise triglycerides. They lower HDL, which is your good cholesterol. A meta-analysis examining data from nearly 95,000 patients found that people taking beta blockers for hypertension had a meaningfully higher risk of developing new-onset type 2 diabetes compared to those on other blood pressure medications. In the Ascot trial specifically, the atenolol group had a 30% higher incidence of new diabetes compared to the amlodipine group. That is not a small finding. Diabetes and hypertension together create a combined cardiovascular risk that is significantly greater than either condition on its own. And here is what makes this metabolic piece particularly concerning for seniors. Your blood pressure medication may be bringing your cuff reading down to an acceptable number. Your doctor looks at that number and feels reassured. But underneath that reading, if you're on a beta blocker and developing insulin resistance, if your triglycerides are creeping upward and your good cholesterol is falling, the actual cardiovascular risk picture inside your body may be getting worse. Even as the surface number looks just fine, you can have a blood pressure reading of 126/78 and still be quietly accumulating metabolic harm. The number on the cuff is not the whole story, and most seniors are never told that. I see this pattern regularly in my practice. A patient in their late 60s on a beta blocker for 3 or 4 years, blood pressure controlled on paper, but they've been gaining weight steadily. Their fasting blood sugar has drifted higher. Their energy is what they describe as half of what it used to be. They've stopped exercising because movement just feels harder than it should. And every one of those changes has been attributed to aging rather than to the medication that may be producing them. When I sit down with these patients, review their complete metabolic picture alongside the current evidence, and have a real conversation about the options, most of them tell me the same thing. Nobody has revisited this prescription since the day it was written. There's also a fall risk dimension to this that I want to address directly because for seniors, it's one of the most important safety considerations in all of medicine. Beta blockers can cause orthostatic hypotension. That's the sudden drop in blood pressure that happens when you stand up from a chair or get out of bed. That brief, dizzy feeling when you rise too quickly. For someone in their 30s, that's mildly uncomfortable. For a senior in their 70s or 80s, that is a fall waiting to happen. Hip fractures in adults over 70 carry a 1-year mortality rate approaching 30% according to research in major orthopedic and geriatric medicine journals. A medication-induced fall is not just a fall. It is a potentially life-changing event. So what does the current evidence actually support as better alternatives for seniors with uncomplicated high blood pressure? 2 medication classes stand out clearly and consistently across both the American and European guidelines. The first is calcium channel blockers. Amlodipine is the most commonly prescribed. The Ascot data strongly favored this class. It doesn't carry the same metabolic burden. It doesn't restrict your maximum heart rate the same way. And a 16-year legacy follow-up of the Ascot trial published in The Lancet in 2018 found that patients in the amlodipine-based group had significantly fewer deaths from stroke over the entire follow-up period. The cardiovascular protection extended more than a decade after the original trial ended. The second strong alternative is ACE inhibitors and their related class called ARBs, which stands for angiotensin receptor blockers. Medications like lanepril, ramipril, Lortin, and Ulmartin have shown consistent benefit in senior populations. They have protective effects for kidney function. They show better outcomes in patients managing diabetes or blood sugar concerns. And a meta-analysis in the Journal of the American College of Cardiology found that ACE inhibitors and ARBs were associated with significantly lower new-onset diabetes risk compared to other antihypertensive classes. For seniors already managing blood sugar or sitting in the pre-diabetic range, that distinction is clinically meaningful. ACE inhibitors do cause a persistent dry cough in about 10 to 15% of patients. If that's you, an ARB works through a similar mechanism without triggering the cough. Now, I want to describe two types of situations I see regularly that illustrate both sides of this conversation. The first is a patient in their late 60s on metoprolol for 4 years for blood pressure alone with no other cardiac history. Their energy has declined. Their fasting blood sugar has risen. Their weight has increased without any major lifestyle change. When we review their complete picture against current guidelines and discuss the option of a supervised transition to amlodipine, the conversation opens up in a way that simply never happened at any previous appointment. The second situation is a patient with a history of atrial fibrillation and hypertension. For that person, the calculation is completely different. The rate control benefit of a beta blocker for their rhythm problem changes the entire risk-benefit picture. Same medication, different patient, completely different answer. And this is the most important thing I want you to take away from today. Beta blockers are not universally wrong. For certain conditions, they remain the right and medically necessary medication: coronary artery disease, a history of heart attack, diagnosed heart failure, certain arrhythmias. In all of those situations, the evidence supporting beta blockers is solid and well established. And I'm not questioning it for a single moment. The conversation I'm having today applies specifically and only to seniors whose one and only diagnosis is uncomplicated hypertension, elevated blood pressure with no accompanying cardiac condition. If that is your situation, the question of whether your current medication reflects the best available evidence from the last 20 years is a completely legitimate and important question to bring to your doctor. Here is exactly what I want you to do with this information. For specific steps, the first step is to look at your current blood pressure medication and identify whether you're taking a beta blocker specifically and only for hypertension. The names to look for are metoprolol, atenolol, bisoprolol, propranolol, and carvedil. If any of those names appear on your medication list, and your only diagnosis is high blood pressure with no heart failure, no prior heart attack, and no arrhythmia, that is the exact situation this conversation is about. The second step is to write down 3 specific questions before your next appointment and actually bring them with you. Ask your doctor, was my beta blocker prescribed specifically for blood pressure? And does that choice still reflect current ACC/AHA guidelines given my complete health picture? Ask, have we reviewed my fasting blood sugar, triglycerides, and HDL levels recently in the context of my current medication? And ask, am I a candidate for a supervised transition to a calcium channel blocker or an ARB, given what the evidence now shows for uncomplicated hypertension in seniors my age? Those 3 questions will open a conversation that is far more specific and productive than a standard blood pressure check. The third step is to request a formal medication review if your blood pressure prescription hasn't been formally reassessed in 2 years or more. This is not an unusual request. This is just good medical practice. Guidelines change. Evidence evolves. The medication that was standard of care in 2008 may not reflect what those same guidelines recommend in 2025. You are entitled to ask for a review, and any physician practicing evidence-based medicine should genuinely welcome that conversation. The fourth step, if any transition is discussed, is to confirm the tapering schedule explicitly. Responsible beta blocker transitions are done gradually over 4 to 8 weeks minimum. Your doctor should be monitoring your blood pressure and heart rate throughout that entire process. There is no rush, and there should be no shortcuts. I also want to talk about what you can do right now today without changing a single medication, because the lifestyle factors that directly support blood pressure control are genuinely powerful, and they're within your control starting this week. Daily physical movement, even just 20 minutes of walking at a pace that slightly elevates your breathing, has been shown in multiple trials to lower systolic blood pressure by 4 to 9 points. That is a clinically meaningful reduction comparable to the effect of a low-dose medication in many patients. Reducing sodium intake to under 2,300 milligrams per day has been shown to reduce blood pressure by 2 to 8 points. And the DASH diet, which is high in fruits, vegetables, and low-fat dairy, was shown in a clinical trial published in the New England Journal of Medicine to lower systolic blood pressure by 11 points in hypertensive patients. None of those lifestyle changes require a prescription. None of them carry the metabolic burden of a beta blocker, and all of them compound with whatever medication strategy you and your doctor decide is right for your specific situation. I tell every patient the same thing. Medication is one tool in one toolbox. It is not the only tool, and in many cases, it is not even the most powerful one. The most powerful tool is the daily decisions you make about how you move, what you eat, how you manage stress, and how much quality sleep you get. Those decisions happen every single day. Medication happens once in the morning and then disappears from your awareness. The daily decisions never disappear. They compound quietly in the background of your health for years. Let me bring this all the way back to where we started. That exhaustion when you climb the stairs, that weight that keeps creeping upward, that tiredness that sits on top of every morning. No matter how early you went to sleep the night before, if you've been attributing those experiences to getting older, that's completely understandable. Most of the seniors I speak with do exactly that. But now you know there is a specific, documented, well-researched reason why a beta blocker can produce every one of those experiences in an aging body. And you know that the current medical guidelines in the United States have moved away from recommending this medication class as the first choice for uncomplicated high blood pressure. You also know that there are well-studied, widely used alternatives with better cardiovascular outcome data, better metabolic profiles, and less impact on the exercise capacity and daily energy that determine the quality of your life at 60, 70, and 80 years old. You are not stuck. You are not locked into a prescription that was written years ago without question. You have the right to walk into your doctor's office with research-informed questions and to expect a conversation that genuinely reflects the current evidence. Your blood pressure matters enormously. The medication you use to manage it matters just as much. And you deserve a treatment plan built on what the science actually says today, not what it said 20 years ago. I'm Dr. Robert Harrison. If what I shared with you today felt important, please hit that like button and subscribe to this channel. And please share this video with someone you know who has been on blood pressure medication for years without a single conversation about whether the current evidence still supports that choice. Because sometimes one video, one conversation, one question asked in a doctor's office at the right moment changes everything. Drop a comment below telling me the name of your blood pressure medication. I read every single one, and your question may become the next video on this channel. Thank you for trusting me with your time today.